So right, now we go for differential diagnosis of trigeminal neuralgia, right? And before really I go into differential diagnosis of trigeminal neuralgia, it becomes a part of, facial pain, right? We must know trigeminal neuralgia is not the most common cause of facial pain. The most common cause of facial pain, right? Most common causes of facial pain are basically, yes, they basically related with the teeth and temporomandibular joint. This is very important. It means that in a patient with trigeminal neuralgia, or when you're suspecting trigeminal neuralgia, or you're suspecting any type of facial pain, you must examine the oral cavity very clearly, right? This is one thing. Now, so there can be teeth, or there can be temporomandibular joint, and then of course pain due to sinusitis. Inflammation in the paranasal sinuses, right? I will make a simple diagram that how the pains can be. These are different patients, and I will try to show you the different pains, right? Very briefly. Now, actually, the pain which is related with the trigeminal neuralgia, as we discussed, it is like electric shock like pain from the angle of the mouth. Is that right? And the pain which is related with sinus, this is trigeminal neuralgia with sinusitis. It is felt on the temporal. So what is this? Frontal bones when there is frontal sinusitis, or it is felt on the cheekbone, which is basically maxillary sinusitis, right? So you can say it is like this is the pain distribution, right? This is due to sinusitis. Is that right? And then there can be pain which are classical case of migraine. In migraine, that is the usually half of the face, right? Even though there are cases where can be bilateral, but a typical case of migraine, classical case of migraine, usually it is unilateral. But remember, cases of migraine are not diagnosed only on the unilaterality. There are cases which are bilateral. Then there can be a pain which is just periorbital around the eye, right? It's a very severe pain, unilateral pain around the eye, and this is called cluster headache. I will tell you the other features also. I'm just showing you the simple. Now, another way of pain which can be there is tension headache. Tension headache is like a band, yes, like a band-like pain, or there's a heavy weight on head. Is that right? This is the distribution of, you can say, tension headache. But we are not doing the headache DD at this very moment. We are just going differential diagnosis of trigeminal neuralgia. So I told you the most common causes of facial pain are teeth, temporomandibular joint, and sinusitis, right? After that, there are two important causes. Number one, which come into differential diagnosis. Number one, migraine. Even though migraine usually produces throbbing headache, but it can also present with facial pain, right? And cluster headache, right? So I will, in differential diagnosis, I will write about migraine and yes, cluster headache. Now, how to differentiate these two pains from the trigeminal neuralgia? Very simple. Very simple. Trigeminal neuralgia is brief pain, sharp pain, and cutting and lancinating pain, right? What happens? And superficial pain. Now, how to differentiate these pains from trigeminal neuralgia pain? The trigeminal neuralgia pain is classically very brief, right? And it is very sharp pain, right? And it is very superficial pain, right? Opposite to trigeminal neuralgia, migraine and cluster headache, both of them are deep pain. They are not superficial, they are deep inside. There are deep pains and they are steady pains. They last longer. They are not just few seconds or 1 or 2 minutes. Is that right?
Yes.
Pain of migraine and pain of cluster headache, the very important feature is that they are, yes, deep and steady pains. And they are very important associated features. As I told you, in classical case of trigeminal neuralgia, there are not many associated features, except that during severe pain, patient may wince his face. But when we talk about migraine, there are a lot of important associated features. Number one, there can be photophobia. Photophobia means what? That patient doesn't like to look at the photo? Or they are afraid of some photos? No. Photophobia means they are phobic to the light. Because light stimulation or any kind of stimulation in patient with migrainous headache exacerbate the headache. Usually these patients, when there is an attack of migraine, there's throbbing headache and they want to lie still, right, in a dark room, because light stimulation irritate. And usually dark room and silent place, because even sounds and voices, they also enhance the pain. So usually we say there is photophobia, they are phobic of light. And there is phonophobia. Phonophobia. You know, there was a time I developed phonophobia. Right? You know why? Whenever there's telephone bell, I was phobic. I've taken loan from many people and I was really in crisis. Even though my friends never bothered me. But I was bothered myself. So I developed phonophobia. But this is not that phonophobia in patients with migraine.
Yes.
Phonophobia means auditory stimulus. Sounds. When a patient is suffering with migraine attack, the sounds exacerbate the pain, exaggerate the pain. Visual stimuli enhance the pain. So patient with migraine have photophobia, they have phonophobia. Remember, trigeminal neuralgia patient do not have photophobia, do not have phonophobia. If they develop such associated features, trigeminal neuralgia, think of there are multiple pathology or dangerous pathology. Right? Then these patients may have GI symptoms, gastrointestinal symptoms like nausea and vomiting. Right? So what I really want to tell you that in migraine patient, what really happens that it may be half-headed pain, hemicranial pain, or in some cases even bilateral. But important thing in migraine is pain is deep-seated and steady over many hours. Is that right? Steady over many hours. It's not matter of seconds and minutes. And secondly, pain is not superficial and it is associated with certain other symptoms like photophobia, phonophobia and nausea and vomiting. In the same way, when we talk about cluster headache is also unilateral pain. Cluster headache is also unilateral. Most of the patient, it is unilateral. As I told you, trigeminal neuralgia in majority of patients is unilateral. Migraine in many patients is unilateral. In the same way, pain of cluster headache is also unilateral. But cluster headache is a pain which is especially around the orbit. Periorbital pain, very severe periorbital pain. I mean, if I need to draw the very sad cluster headache, right? This will be periorbital. You look at the C, it is showing you cluster. C for cluster, periorbital and unilateral on one side. And it has also, the cluster headache has also its associated features. What are the associated features of cluster headache? Number one, not only there is periorbital edema and sometimes red eye. There can be red eye. Injection of conjunctiva. Injection of conjunctiva. Injection of conjunctiva. Right, red eye. Along with that, in cluster headache, patient may have, yes, what is it? Teardrops coming out. What is it? Epiphora. epiphoria. Epiphora is basically in these patients due to irritation in the eye, pain and irritation, there is over lacrimation, and due to watering of eye occur. So severe headache, especially around the eyeball, or periorbital headache, or deep in the orbit headache with what is this? Red eye and epiphora. And with epiphora there is also what is this? Nasal secretions also coming out. Rhinorrhea. What is it? Rhinorrhea. Running nose. It doesn't mean nose is running around. It simply means that there is running nose. Is that right? So what I'm saying, and sometimes in these patients even there can be Horner syndrome. Horner syndrome. We have a separate lecture on Horner syndrome in which there's partial ptosis and there is, yes, what happens in Horner syndrome? Horner syndrome, sympathetic supply, oculosympathetic pathway is disturbed, right? And sympathetic fibers are not supplying the ocular and orbital structures. So that may produce, number one, there is partial ptosis and loss of sympathetic supply to the dilator pupillae. That will produce constriction of pupillae because sympathetic fibers produce dilation of pupillae. Is that right?
Yes.
And when in Horner syndrome, sympathetic fibers are not working, so the loss of dilator pupillae function will lead to unopposed action of constrictor pupillae, and that will lead to what? Meiosis. So partial ptosis with meiosis, right? And half of the face, maybe there is loss of sweating, anhidrosis, right? And anophthalmos apparently looks as if eye is little depressed inside. So what I'm saying, that again, how to differentiate trigeminal neuralgia pain from migraine pain and cluster headache? Again, trigeminal neuralgia pain is superficial. These two pains are deep. Trigeminal neuralgia pain is very sharp. These are dull and throbbing, or right? Trigeminal neuralgia pain is short duration. These are steady and prolonged. And how to differentiate from each other? Again, and with the trigeminal neuralgia does not have such associated symptoms, but these pains have certain associated symptoms. As I told you, migraine has photophobia, phonophobia and GI symptoms. In the same way, cluster headache has epiphora or rhinorrhea or Horner syndrome, right? That is why I was mentioning in previous video that take care in trigeminal neuralgia, what are the associated symptoms? Is that right? The associated symptoms, if in trigeminal neuralgia are there like sensory deficit, then trigeminal neuralgia is not classical, it is symptomatic.
Yes.
You remember? Or if there is interictal numbness, you more think of symptomatic trigeminal neuralgia, right? Then we come to another thing. So rarely we may come across a patient who has a double problem. Number one, patient is really suffering from trigeminal neuralgia and also really suffering from cluster headache, right? If patient has a double pathology, then we use the term cluster tic. Cluster tic. What is cluster tic? These are those patients, very unfortunate patient, who are having attacks of paroxysmal attack of, you can say, trigeminal neuralgic pain, and along with that they are also having another pathology, and that is cluster headache. There are two diseases in the one person. Of course, one disease does not make you immune to the other disease. So if there's a combination, we use the term cluster tic. Then another pain which I would mention, that is about temporal arteritis, right? Temporal arteritis, what happens in this patient? Temporal arteritis, usually it's 50 plus patients, and temporal artery, patient do have ears also. So temporal artery, which is going over here, this artery gets inflamed. But not only this artery is inflamed, the autoimmune attack, immune mediated damage to the temporal artery, but not only temporal artery, also many arteries, especially very dangerous attack on the retinal arteries. On retinal arteries, retinal arteries. So the only thing why we call it temporal arteritis, because it's easily palpable. In these patients there is pain in temporal area, and it is again, even though it is superficial pain, but it is prolonged pain. Trigeminal neuralgia is superficial pain but short pain, and this is superficial pain but prolonged pain, and plus with that there is tenderness, and sometimes you can palpate this inflamed artery as a cord, temporal artery as a cord. Is that right? Palpable temporal artery. So in temporal arteritis, right? Here the pain is in this area, right? In temporal arteritis, there is pain, and you know, one of the very strange way to diagnose patient says when he is combing, he feels the pain in this area. Of course, person like me is not going to comb it, right? But anyway, I'm not talking about my baldness. So what I'm talking about, that temporal arteritis is an immune-mediated attack on the blood vessels. And when temporal arteritis is there, that produces superficial facial pain and temporal area headache, right? In this patient, temporal arteritis, usually ESR is high. Trigeminal neuralgia does not have ESR high. And another important thing, that there are myalgias and other systemic features like low-grade fever. Systemic features like low-grade fever, right? It's widespread immunological mechanisms damaging the arterial system. But whenever in your life you think of temporal arteritis, or someone talk about temporal arteritis, there should be one idea flashing in your mind. You know what is that? What is that? Temporal arteritis. Whenever this word comes to your mind, there's one idea which should come to your mind immediately after this word temporal. What idea should come? Prednisolone. Prednisolone 60 milligram per orum per day. Wow. Immediate. Why I'm saying this? Again, let me repeat it. It's worth repeating it. Whenever in your life you think your patient has temporal arteritis, immediately your mind should go directly to one thing. Where is prednisolone? If there's 5 milligram prednisone tablet, take the 12 tablets. Give the patient 60 milligram prednisolone immediately per day. You know why? It saves the eyes. Because in temporal arteritis, when retinal artery is attacked by the autoimmune process, retinal artery becomes inflamed, blood cell supply to retina finish. There's ischemic degeneration of the retina and permanent irreversible blindness. So just giving this prednisolone, you save the eyes of the patient. It's very important. If you remember this, I'll be very happy that I worked really good and it was worth it. What is that? Temporal arteritis in all your life, whenever you think of, don't think of it is one type of headache. It's a very dangerous type of headache. Patient sooner or later will come with the visual problem, sudden blindness, or some very unfortunate patient are first time diagnosed that they come to the doctor that they suddenly develop blindness. Is that right? So if patient comes with temporal arteritis, this is the risk of irreversible permanent blindness, or sometimes bilateral blindness risk. So what you do? You just take blood sample for ESR, because in these patients ESR is very high, and immediately start giving what? Prednisolone steroid to save the eyes. To save the eyes. I hope you will remember it. Yes. This problem, that sudden loss of vision in temporal arteritis, this loss of vision is called amaurosis fugax. Amaurosis fugax. or sudden, severe, irreversible, permanent loss of vision, right? So anyway, let's come back. So what I was telling you, that temporal arteritis is also facial pain. Trigeminal neuralgia is also facial pain. How do you differentiate? Temporal arteritis is, even though superficial, trigeminal neuralgia is also superficial, but trigeminal neuralgia is brief, and it is like a pain which is sharp, cutting, stabbing, lancinating, piercing, electric shock like, but temporal arteritis pain is dull and diffuse and on side of the temple, and it may be having involved area tender, and it's prolonged pain, and maybe artery may be felt as a cord. What you do? Immediately give the steroids, right? And of course you take the sample for the what? ESR, and you do biopsy of the artery. Is that right? So this is about temporal arteritis. Again, trigeminal neuralgia, how to differentiate from migraine? Migraine may be also unilateral. Trigeminal neuralgia may be also unilateral. But migraine is deep and steady pain, and trigeminal neuralgia is sharp, brief, superficial pain. Sharp, brief, superficial pain. And migraine has associated features like phonophobia, photophobia, or GI symptoms. How to differentiate trigeminal neuralgia with? Cluster headache. Again, both are unilateral facial pain, but cluster headache is basically periorbital severe pain. Almost most of the patients unilateral, right? And with redness of the eye, and with that lacrimation, epiphora, and rhinorrhea, maybe Horner syndrome. Maybe Horner syndrome, and that is also deep and steady. And of course you know that your trigeminal neuralgia is superficial, sharp, and brief. Is that right? Then we come to the last thing, but not the least, that we have to differentiate classical trigeminal neuralgia from multiple sclerosis, MS. As I have discussed previously, MS is what is wrong in the MS? That there is central demyelinating lesions which are produced by the T cell mediated immunity, and that produces multiple plaques in central nervous system, right, due to reactive gliosis. But what really I want to tell you, when you think of that facial pain is due to multiple sclerosis, and how to differentiate from a classical case of trigeminal neuralgia, very simple. In multiple sclerosis, number one, the disease, this type of symptomatic trigeminal neuralgia is seen in younger patients, and number two, usually it is bilateral. Number three, there will be sensory deficit. There will be sensory deficit, and of course some other features of multiple sclerosis may be found as well, right? Then the most dangerous differential diagnosis. You remember I told you classical case of what? Trigeminal neuralgia and symptomatic case of trigeminal neuralgia. So trigeminal neuralgia can be produced by mass lesions. Yes. Mass lesions. And I told you in cerebellopontine angle. Again we go back, this is midbrain, here is pons, and here is medulla and spinal cord, and here is cerebellum. This area is called cerebellopontine angle. Is that right? Here is your fifth nerve going out, here is your seventh, and here is sixth. This is eighth. Again, from midpontine which nerve is going out? Fifth, trigeminal, and here is the eighth, and here is the seventh. Is that right? Now, if there is a mass lesion in this angle, what is this angle? Cerebellopontine angle. Cerebellopontine angle. CPA, cerebellopontine angle. Mass lesions, they may also produce trigeminal neuralgia, but that is not classical trigeminal neuralgia. We call it symptomatic trigeminal neuralgia. In these cases, what is there? That there may be underlying cause, as I mentioned previously. There can be aneurysm, or there can be neurofibromas, schwannomas, or meningiomas, right? And how do you differentiate this from the classical case of Trigeminal neuralgia. These cases in the DD, these patient will have sensory losses.
Yes.
Sensory deficit, number one. Number two, these patients will have interictal facial numbness. That in between the two attacks of trigeminal pain, neuralgic pain, the face, part of the face will be numb. And with that, they may have other features, dangerous features, that not only trigeminal neuralgic pain is there due to irritation of the fifth nerve, but there may be evidence of damage to the seventh nerve and eighth nerve. Seventh nerve damage may present as hemifacial paralysis, and eighth nerve damage may come as deafness or tinnitus or vertigo. Is that right? So this is about differential diagnosis related with trigeminal neuralgia. Do you have a question?
No, sir.
You don't have any question? Okay. Next lecture we'll talk about the management of trigeminal neuralgia.